microphones off. Just making sure something on my side. Okay. Stand by, guys.
Alrighty, will you share my
Presentation.
just whatever I have to say?
Okay.
Let me know when you're good.
MJ, happy days, hey?
Happy days.
Okay, stand by, guys. Okay, MJ, you can go for it when you're ready.
Good day, doctors. Thank you for joining us for another Genoa Underwriting Managers CPD presentation. Here at Genoa, we are passionate about the continued education of our insureds, and we firmly believe that by keeping you informed of both ethical and clinical risks, we can ensure that we build a sizable client base. Do you want me to... No worries. I'll start again. I messed up with sizable, so it's okay. Okay. Good day, doctors. Thank you for joining us for another Genoa Underwriting Managers CPD presentation. Here at Genoa, we are passionate about the continued education of the insureds, and we firmly believe that by keeping you informed of both ethical and clinical risks, we can ensure that we build a sizable client base. This is important to you, the insured, because by ensuring only those practitioners that are focused on risk mitigation, we can ensure that we offer you sustainable premiums, and more importantly, that we mitigate the cross-subsidization of premium between high and low-risk practitioners. I'm joined by Dr. Brad Byra, who will be delivering his talk on medical errors and social media. Dr. Byra is an accomplished speaker who has spoken all around the world on medico-legal matters. Dr. Byra is an integral member of our team, and we are very proud to have him and his expertise. With that said, Brad, over to you.
Should we do one more quickly?
Yeah, sorry, the camera was in the way of the last bit, so I couldn't actually. Yeah, that's 100%. Thank you.
As you're ready.
From the top, eh?
Yeah.
Good day, doctors. Thank you for joining us for another Genoa Underwriting Managers CPD presentation. Here at Genoa, we are passionate about the continued education of our insureds, and we firmly believe that by keeping you informed of both ethical and clinical risks, we can ensure that we build a sustainable client base. This is important to you, the insured, because by ensuring only those practitioners that are focused on risk mitigation, we can ensure that we offer you sustainable premiums and, more importantly, that we mitigate the cross-subsidization of premiums between high and low-risk practitioners. I'm joined by Dr. Brad Byra, who will be delivering his talk on medical errors and social media. Dr. Byra is an accomplished speaker who has spoken all around the world on medico-legal matters. Dr. Byra is an integral part of our team, and we're very proud to have his expertise available when our practitioners raise medico-legal queries. Please enjoy the presentation. Brad, over to you.
Okay, great. So we can kick off. So hello and welcome to today's Medical Errors and Social Media Risks presentation. The purpose of today's presentation is to have a look at how we practice and how we execute what we do in our practices in a way that is the safest, healthiest, and most compliant mechanism for ourselves as practitioners, but also in a way that allows it. Yeah.
Sorry, Brad. There was after I finished, there was a weird thing that happened. Do you mind starting from the top, whenever you're ready?
Not at all. You just tell me when you're ready for me to stop.
Okay, stand by, and you can go for it when you're ready.
Hello, everyone, and welcome to today's presentation on medical errors and social media risk. The purpose of today's conversation is to go through some ideas of how you can improve in terms of your own clinical practice and in terms of your practice administration, your focus on providing safe, quality healthcare that lowers your risk of ending up in a position where you may or may not end up on the wrong side of a patient complaint. We're going to do this presentation in 2 phases. In the first part, we're going to look at professional indemnity and common medical errors. And in the second part, we're going to have a brief look at social media risks. So to start off with, when we look at medical professional indemnity, we need to recognize a couple of behaviors that we do that can contribute or lead to there being a patient safety incident. Now, a patient safety incident is any time in your care with your patient, from the first time you speak to them until after your last discharge of them as a patient, where there might be a risk of an adverse outcome because of one of 2 things. The first thing that could cause a patient adverse outcome or a poor outcome or a preventable undesirable outcome is what is called an error of commission. And an error of commission happens because of something that you've done. It could be because of a prescription that you've made or a decision that you've made. It could be because of a slip of your hand, or it could be because of a suture that wasn't done effectively, or because your infection control wasn't as clear and appropriate as it might have been. So those are errors of commission. And often when we start looking at negligence, we would look at them in terms of, did you do what you could have done, and did you do it safely? We're going to talk about that a little bit more as we go through the presentation. We've then got errors of omission. And an error of omission is the failure to take the right action or a task that you've left undone. So that could be missed care, it could be a gap in your care, it could be an incomplete disclosure of a complication, would all fall part of an error of omission. So either an error by commission, something that you've done, or an error of omission, something that you've left out, could lead to a lapse in the quality of care, which could lead a patient either to be validly or non-validly, but socially aggrieved by the care that they've got with you. So at this point, as we go on, I'd like you to think in your practice, what are the things that you may or may not be doing that could lead to a patient safety incident in terms of your sterile environment, in terms of your patient engagement, in terms of your procedures that you do. And then I'd also like you to think of, what do you potentially leave out? And if you were to leave that out, what would the implications be to the standard of care, which would be the perfect or ideal standard of care that you would be giving your patient, or that you as a patient might want? There's a movie that William Hurt starred in a few years ago, where he is a surgeon and he ends up needing care. And he realizes through the journey of his own care that he gets as a patient as to how he has, by commission and by omission, not treated people as intimately, as tenderly, or as gently as he might have. So that's a movie worth watching to give a good example of what our patients experience versus what we think they experience. So I put the slide up because there's often a joke around the medical alphabet that says we get into medical school because we write so badly. And if we handwrite our applications into medical school and the school can read it, they throw it out. Now, when we look at our alphabet, and if you look at your scripting process or your referral process, the question that I would ask you is, can the person receiving your instruction read your instruction in a way that is unambiguous and safe? So we look at that, and as we go through, let's talk about the concept of a medical misadventure. So any error or omission of diagnosis or treatment, or the procedure that you perform, or the supervision or timeliness of care that you give that results in a perceived or a putative injury to patients would be regarded as a medical misadventure. Now, the test for this, and you'll see there, I've put in, and I will continue to do so through this presentation, some examples from cases within South African law, as well as some references from around the world. The application of the necessary skills needs to comply with the standard of the reasonable practitioner. Now, this means, in very simple terms, that everything you do needs to have a degree of reasonableness to it. What does that mean? It means that another person with similar or the same training to you would do the same things that you've done. And if they would do something different with a higher standard of care, either in the diagnosis or in the procedures of performance of your treatment, or in the supervision of your patient, or in the timeliness of their care, if they would do it differently from you, you may find that your standard of care might be lacking, and that may lead to an outcome that is undesirable for the patient, and that would lead to the concept of a medical misadventure. Now, there is a difference between a medical misadventure and clinical negligence. A medical misadventure can happen. A complication can occur. We are human. There's a book that was written several years ago on this called To Err is Human. And we recognize that an error in diagnosis or treatment or follow-up of care is excusable, but a mistake can be regarded as negligent. Now, your error of judgment may or may not be negligent. That assumes that you have an error of judgment. But an error of judgment may or may not be negligent, and it depends on the error, and it depends on that comment of what would the reasonable person have done. Would a reasonable person have made the same kind of error? Might they have foreseen the complication? Might they have communicated in the same way? If the reasonable person would not have communicated in the way that you did, or made the error of judgment that you made, then it's more likely to be considered a negligent outcome as opposed to a medical misadventure. And that's why you'll see here, we're going to start and end with comments made by, in a judgment in 1924 between Van Wyk and Lewis. And here we're saying that the true nature of the inquiry is into the reasonableness of the conduct of the practitioner or the practitioners. So bear in mind, as you go through in your practice now, would a missed outcome, would a misdiagnosis, would a secondary infection at a suture site, would a adverse reaction to the medicines that you prescribe be regarded as a medical misadventure, or would it be regarded as clinical negligence? And if you were to apply the reasonableness test of your conduct versus those of other practitioners with your qualifications, would you be found meeting and exceeding the standards, or might you be found lacking in those standards? So if we were then to pause and say, well, what is a medical error? A medical error, and the key words here are a preventable adverse effect of care. It doesn't matter whether it's evident or harmful to the patient, it's whether it was a preventable adverse outcome. Now, this could include an inaccurate or incomplete diagnosis. It could include an inaccurate or incomplete treatment. It could include the treatment of a disease. It could include the treatment of an injury or a syndrome or a behavior or an infection. It doesn't stipulate what the preventable adverse effect of care was, simply that the error is a preventable adverse effect. Now, if you were to reflect back on your last month or your last 6 months, have you had incidents with your patients where there was a preventable adverse effect of care? If so, how have you listed and recorded that? And if not, is that because either you've provided excellent standards of care, or because the patient hasn't come back to you, or you haven't done a follow-up to know that? But it's also important, I suppose, at this point to recognize that a medical error may or may not be negligent. Medical errors happen. Medical error could fall into the category of a medical misadventure. It can fall into the category of negligence. And it all depends on whether you've met or failed to meet the reasonable medical standards that might be expected of you. So a lot of the effort as you go through this kind of a presentation is the self-reflection on what you're doing in your practice. There are health professions guidelines under the ethical guidelines as to what you can and can't do and what you should or shouldn't do in terms of safe practice. But when we look at this after the fact, where there has been a diagnostic opinion that has led to a treatment, that has led to an outcome that is either actual or perceived to be less than the patient's expectation, that may or may not be harmful to the patient, or where the patient may or may not have experienced harm. The test will always be whether you've met and exceeded the reasonableness standards. So Joint Commission International, through their efforts in understanding medical errors, has created what they call a taxonomy of medical errors. And it looks at 5 different components of a medical error. The first thing that it looks at is the impact of that error. We're going to have a look at that a little bit later. They also look at the type of error. They look at the domain, and we're going to unpack that now. They look at the cause of the error, and they look at whether that error was preventable or what steps of prevention you took to limit that error. So in the example that's on the screen here, you can have a look at the domain or the setting. Did this error happen in your office? Did it happen in the hospital? Did it happen as part of ambulatory or outpatient care? Did it happen in the rehab unit? Was this an error in a nursing home or a long-term residential home? Did this error happen at a hospice? And then in this example, in the hospital, did it happen in the emergency room, in the operating room, in the ICU, or in the nursing unit? The reason that this becomes important is when you start looking, in your case, at the transitions of care that you do with your patients, understanding how often you transact with the patient, whether you're in the office, whether it's via telephony, whether you're doing telemedicine, or you're providing telehealth, whether your script then goes to the pharmacy and the pharmacist fills that script correctly or incorrectly, all creates part of that universe, which is where your medical error or a medical error can occur. So if we take that one step further, we can look at this in terms of how the impact of a medical error is assessed in terms of degree of harm. So that's your impact that we're looking at. When we look at that impact, you'll see that there's 2 components. There's the medical impact, which is your clinical components, physical, physiological, and psychological, and then there's your non-medical impacts. When we look at that, we're going to look here at the physiological and physical, well, actually the psychological and physical, and then on the non-medical side, we look at what are called the ESLIs, the economic or environmental, social, and legal impacts that your care may have had. So the economic impact that your care may have had is that it's created a health shock for that patient and they can't afford to pay. On a social impact, it may have altered the family dynamics or the ability of the patient to perform normally, to perform socially, to move in an unhandicapped or an uninhibited way. It may have created a permanent or partial residual disability, and it may or may not have infringed on their legal rights in terms of their constitutional rights from a preservation of their bodily integrity. And those are important things to consider. We're not going to cover that specifically now. Now we're going to look more at the psychological and physical implications. Now, bear in mind when you look at this, the impact can go from, in its worst case, profound mental harm, to, in its best case, no harm or no undetectable harm. The challenge that you have here is, how does one measure that on a scale that says, yes, the person has or hasn't experienced harm? If I say, I'm really upset and I'm aggrieved and I'm traumatized by this, would this be regarded as minimal permanent harm, or moderate permanent harm, or mild temporary harm, or severe temporary harm? So the scale of which to measure this is very, very difficult. Physically, it relates to the same thing. Physically, we would go from the worst outcome of death and the best outcome of no harm and no undetectable harm to severe temporary or severe permanent harm at the bottom end of the scale, or no detectable harm or minimal temporary harm on the best part of the scale. So every outcome that needs to be assessed has to be considered in terms of how the patient perceives their outcome and how a third party or an independent party would assess the outcome of your care. Now, you can see just from this, when we only look at the higher level buckets of psychological and physical harm, that it can become quite complicated to then assess what the impact might be. So at this point, let's just pause and take a look and say, what are the 10 most common medical errors as they catalog. So the technical medical error, which would be from the first slide, you'll have noticed an error by commission, is something that you've done. It's a technique that you've done, or a procedure that you've done, or a failure to execute due and diligent care. Equally, in the perceived medical errors, and this comes out of several thousand professional indemnity claims, is your failure to use indicated tests, your avoidable delay in treatment, your failure to take precautions, and your failure to act on test results are the top 5 most common causes for medical errors. If we take the next 5 to give us our 10, your inadequate monitoring after a procedure, your inadequate patient preparation before a procedure, inadequate follow-up after treatment, avoidable delay in diagnosis, and improper medication dose or methods used. So you'll see in these top 10 that there's a lot going on, first in terms of what you technically should be doing, the speed and appropriateness of the tests and your actions in order to effect a treatment or an intervention. But there's also the question of, did you follow up after the procedure? Did you follow up after the treatment? And a pause of reflection for you now is, when you discharge a patient either from your rooms or from the hospital, following either an in-room treatment or a day clinic treatment or a hospital treatment, what is your mechanism for following up with that patient? Are you following up with them well? Do you have a scheduled follow-up? Is there a checklist that you follow to make sure that that follow-up is occurring? Are you recording your post-treatment or post-discharge or post-prescription follow-up? And if the answer is no, this may be an area for you to consider putting another layer of care or another layer of diligence into your patient management structures. So there are some recurrent themes that come up when we start looking at how one reduces lawsuits. And the recurrent themes, the first is the lack of effective communication between you as the physician or your healthcare practitioner and the patient. Now, in this case, the key word here is efficient communication, key words. It's difficult to know what the right amount of communication is. But if you go through the Health Professions Council requirements in terms of their ethical guidelines, and you look at the guidelines that relate to your duties as a practitioner in terms of booklets 1 and 2, and you look at your duties in terms of booklet 4 of informed consent, that would fall into this area of effective communication. Have you shared with the patient your outcomes or your expected outcomes or your reasoning as to how you got to your diagnosis and your reasoning as to how you got to the treatment regime that you are recommending, and listen to what the patient's expectations are so that the two are aligned? Oftentimes what happens is the expectation between yourself and what you regard the outcome to be, what the patient regards the outcome to be, are fundamentally different. I recall in one of the early conversations we had like this, one of the surgeons declared, they said, well, when I do a surgery, I regard the success of the surgery as having removed the cause of the pathology, or having removed the pathology, or having removed the cause of the dysfunction. So when the surgery is concluded, I'm really happy if I've managed to replace the, let's take it as a shoulder, replace the acromioclavicular joint in a position where it's less likely to have an impingement syndrome. When the patient wakes up, they expect to have full motion and be ready to move. The disconnect between those two is that I'm content with the surgery, that the physical restructuring was done, and the patient is still discontent because they've got months of rehabilitation and they don't have full range of motion when they wake up and they still have pain. So the alignment between expectation is really important. You'll see later, and I'm going to raise it now, is the longer the space between a patient being informed of their need for a procedure and the actual time of that procedure, the higher the patient's anxiety levels. And the higher the patient's anxiety levels, the more stress they feel. The more stress they feel, the more likely they are to have a perception of adverse outcomes. So you'll see that communication errors are a root cause, a fundamental reason for malpractice claims. So when we start talking about root cause analysis, I'd like to just at this point suggest that those of you that have an interest in the understanding of how a malpractice claim or the taxonomy of a malpractice claim comes to be, is you should go and watch a YouTube video on a case called the Michael Colombini case. Michael Colombini was a 6-year-old child who was playing in the playground and fell over and lost consciousness. And when they took him into the emergency room, they were worried that because he'd fallen down, that the fall had created a cranial fracture, and that was the cause of his unconsciousness with a subdural hematoma. Turned out that the good news was he didn't have a fracture. The bad news was he did have a tumor. And so they took him into surgery. They cracked the skull. They did their best to remove the tumor. And subsequent to that, the anesthesiologist takes this young man, takes him down into the imaging unit for the magnetic resonance imaging, and hooks him up to the oxygen. And so they're now going to do the post-surgical assessment to see whether they got all the tumor out. At that stage, the anesthesiologist realizes that the oxygen is not flowing and calls to the technician on the other side of the room to ask for assistance. Now, usually there would be 2 technicians in the room, but one was in the back. The first technician in the front goes into the back, but because you know that MRI units are very noisy, they are now acoustically separated from the anesthesiologist, who's becoming progressively more anxious because the patient is going into distress and he needs the oxygen. They at the back can't hear these 2 technicians, so they continue the exercise of changing the oxygen cylinders. But a nurse from outside hears the anesthesiologist and runs into the suite and brings in a metal oxygen cylinder. But because the MRI is energized, it pulls the cylinder into the unit, bashes the young unfortunate child on the head, and the child dies. So in the subsequent investigation, they start understanding, where did this cause of this child's death come from? Did the cause of the death happen because the anesthesiologist didn't take the time early on to make sure that the oxygen was flowing? Did the cause of death happen because the technicians weren't where they should have been doing and that the unit wasn't prepped prior to the anesthesiologist coming? Did the cause of death come because the nurse was negligent in bringing an oxygen cylinder into the energized MRI unit, despite the fact that there was this emergency call for support? Did the cause of death come because the MRI unit door wasn't closed to prevent unauthorized entry from other people? And so going back through that, looking at the policies, the procedures, and the practices is how one comes to a root cause. So what you might do in your practice is look at your practice and say, where there's been an adverse outcome, do we have all of the steps in place in our practice to limit this? And at this point, I would suggest those of you that haven't read it, that you read a book by Atul Gawande, the general surgeon who worked for the World Health Organization. And that book addresses what Atul Gawande found to be a common cause of adverse outcomes or poor results in medical practice. And that was the absence of a checklist, or the absence of the 3 or 4 or 5 steps that one should always follow when one does a particular procedure. Now, in your practice, do you have a checklist for each type of procedure that you do? Do you have a checklist that includes the informed consent that you have with a patient? Does that checklist, as an example, include the type of condition that you assessing? Does it include an explanation to the patient of the treatment options that they have and the risks and potential consequences of each of those treatments? And does your checklist also include potentially the financial and cost implications? Because often it's the cost implication that creates the unhappiness in a patient. So the third recurrent theme for you to bear in mind is the theme that the stress that's associated with residual disability is what causes patients to be anxious. Now, that residual disability could be imposed by the disease, and it could be caused by the treatment itself. So either one of those could result in a patient feeling aggrieved. Now, if your communication with the patient is better and your informed consent with the patient is better, the likelihood that your and the patient's understanding of the outcomes would be closer aligned to each other. So, as we spoke about slightly earlier, preoperative anxiety is the most frequent emotional factor prevalent in patients. The higher their anxiety preoperatively, the higher they are, the more likely they are to have a moderate to severe post-operative pain response. And if that's the case, they are more likely to have a complaint. So my question for you is, if you are scheduling procedures with your patients and the procedure is a week to 2 to 3 to possibly 4 weeks away, are you suggesting to your patient to have some preoperative counseling so that the patient's stress levels are managed, their anxiety levels are managed, and their expectation levels are managed? And if not, might this be something that you would consider in your practice? And if so, is this part of your informed consent that you're explaining to a patient that preoperative anxiety can lead to postoperative perception of poor outcomes? So a little bit of self-reflection before we move on. And I'd like you to do the self-reflection, taking into consideration the first slide where we spoke about errors of omission and errors of commission. In this case, describe the care that you would usually deliver when you have adequate time. What would a perfect patient engagement look like? Now, if at times you don't deliver that care, for whatever the reasons are, what types of care are left out? What types of dialogue are left out? What types of questions in your case history are left out? Once you know that, what clinical care is regularly missed and why? And you may find that you need to write down a checklist that takes you through the steps for you to identify what you may leave out and why. You may leave nothing out, which would be fantastic. But if you were leaving things out, what might you be leaving out? Off the back of that, if you were to leave things out, how might that affect patients? Now, that could affect patients in one of a number of ways. It could affect a patient in terms of the fact that they don't know to call you again or to give you feedback on the care. It may result in a clinical outcome or an infection. It may result in a drug interaction with other medications that they're taking, or it may result in side effects that they don't communicate to you. And then the final piece is, how could these omissions be prevented? It's really important for you as you move through and you look at what a medical misadventure is to understand that anything you leave out would be tested against what the reasonable practitioner of your training would do. If a reasonable practitioner with adequate time would do things that you're leaving out, you would then shift out of this being a misadventure into this being negligent. And that would be your test in terms of errors and omissions. So at this point in the presentation, we're going to just pause and we're going to move on to one of the more emergent medical risks that you would be facing in your practice, which are social media risks. Now, social media risks are significant. They're a very real part of our world right now. And this section of what we're going to do is go through social media risks. Now, I remember back in my early practice days, which was the late 90s, I had a dial-up modem. It was a 256 modem, and you could hear it beeping and tweaking. And at that point, our understanding of the internet was not quite what it is today. By the time I left the practice, which was 4 years later in terms of that practice, to now, I often hear people saying to me, and there was one practitioner who had this on their wall, "My medical degree trumps your Dr. Google." Now, this irony of I must get a faster modem with higher internet access to them is a very real challenge that we have right now as practitioners, because there's so much information out there. There is also so many different media to share information and so many different strategies to share information that staying on top of this is important. Now, the Health Professions Council has within their ethical guidelines booklet, a booklet specifically on managing social media risk. And I refer you to that booklet. It's booklet 16, and that booklet should be read with booklets 2 and 6. So for a description as we go forward here, social media describes any and all online tools and electronic platforms that people use to share content. And that content would include your opinions, would include information, it would include photographs, videos, and any audio surveillance. Now, an example of where this went particularly poorly in one case is a young couple who were visiting the gynecologist. We're in the gynecologist's rooms, and the gynecologist was doing an ultrasound. And while the mother was having the ultrasound, the father was recording the ultrasound on video. And so they were recording the mother, the clinician, and the ultrasonography. They then posted this ultrasound consultation on Facebook. And the outcome that came from that was people started commenting and saying, well, actually what was being said was not correct on what was on the screen. And it ended up creating a significant challenge, not only for the couple, but also for the practitioner, because there were issues on whether this video should have been recorded in the first place. Did the clinician know that this was going to be placed onto social media? And the fact that the clinician had made an inappropriate statement was equally significant. So as you go forward, recognize that social media includes social networks like Facebook and Twitter, WhatsApp and LinkedIn, because you have WhatsApp groups. And once you have a WhatsApp group, that would be considered to be a social network. It also includes content sharing platforms like YouTube and Instagram. It also includes, when we talk about social media, any content that you share electronically via email, via SMS, on an electronic journal, whether you publish it, what you regard to be with anonymity, which is never truly anonymous because there's always ways to identify it. It includes your internet discussion forums, and it includes comment sections on websites. So I would strongly suggest that you review booklets 2 and 16 from the Health Professions Council in terms of what the Health Professions Council regards social media to be and what your obligations are in terms of social media. So social media includes the spreading of scientific information and not medical advice. And so I'll reference you to section 7.10 of booklet 16 of the Health Professions Council. Internet-based tools allow individuals and communities to gather and communicate and share information with each other. When you start to share information, that includes personal messages, images, and other content. And in some cases, it allows you to collaborate with other users, other healthcare practitioners, other professionals. And it allows you to do that in real time. But it does present potential risks to patients and to healthcare practitioners in terms of how you share good and poor quality information. It does potentially expose you to professional image issues. It allows you either, and I would assume inadvertently, to breaching patient privacy. It allows you to potentially violate personal and professional boundaries, and it puts you at risk in terms of your licensing and legal issues. What this means, broadly speaking, if we simplify it, you could make a statement about a patient, or you could make a statement about another professional, and you could post that statement to a colleague. And that colleague could distribute that on a much wider basis than you ever intended. And that could lead you to a very awkward situation. You may share a piece of information with a colleague about a patient, but if you do it without the patient's written consent, you are in violation of that patient's privacy. That second colleague may know that patient, or may identify that patient, or may make a comment about that patient that gets shared more broadly. And that presents for you some significant risks. In addition, you may have different social roles in your community. You may be a member of your religious community, and provide a certain amount of roles in that capacity. In addition, you've got your professional boundaries that are set. You may also have a Facebook page or a LinkedIn page or an Instagram page. And persons who see you as a clinician may also see you in various different social forms or different social environments and connect with you in those areas. That then creates a blurring of your professional and personal boundaries that you need to be aware of. So you do, under your social media obligations, have ethical obligations and responsibilities. You need to bear them in mind, and I'm going to refer you, in addition to booklet 16, to look at booklet 1, which are your general ethical guidelines as a healthcare professional. Booklet 5 talks about your responsibilities of managing confidentiality and protecting and providing information to your patients. So that's protecting their information, providing information to them, and the method and mechanism that you can share their information with others. I'm also suggesting that you look at the general ethical guidelines for the good practice in telemedicine. You'll have noted, and if you don't, I'll share with you now, that due to the COVID pandemic and the issues that we have with the pandemic, the Health Professions Council has extended our scope of practice to include telehealth, where telemedicine was a joint consultation where on one side of the consultation was a healthcare practitioner and the patient, and on the other side, remotely providing digital input or input on a digital platform, was another practitioner. Now you have telehealth, which allows you as the practitioner to engage directly with the patient without another practitioner being present with that patient. How you manage that relationship, what platform you use, whether you're using a platform like WhatsApp video or WhatsApp voice, or whether you're using Skype, or whether you're using Zoom, or whether you're using Starleaf, just to name a couple of different platforms, those are considered to be social media platforms. And how you manage those communications and how you manage that dialogue is vitally important for you. So there is a book which was published recently, and the book said, "Don't film yourself having sex and other legal advice for the age of social media." There's a joke that says, if you don't want to have naked pictures of yourself posted on the internet, don't take pictures of yourself. And so the issue that comes up here, and the reason that I put these, that image, that is the image on the left-hand side, is a book that was published by Penguin Books that you can buy at most bookstores. It's contemporary, and it was published in 2019. You can also see on the left-hand side, and you consider the left-hand side, you'll see on the right-hand side, the Business Insider. This was taken last year. You'll see it was the 24th of October, and it shows the link between a former teacher at one of the schools and the web searches that happened as a consequence of that, that was outside of this person's control. Now, we are now bound by the Protection of Personal Information Act. The last implementation of that act, which now brings it into full force, was on the 1st of July 2020. And it outlaws the acquisition of data about a person, especially about their health or sex life outside the healthcare setting. By having access to a patient's social media profiles, you may or may not find yourself having access to personal patient information that hasn't been shared with you in a healthcare setting. You're going to have to make very clear delineations about what you source from a patient in terms of their declaration of their health status and what you have access to of broader social media. And at what point are you violating that patient's individual privacy rights by looking at them in a environment that's outside of your clinical or your therapeutically privileged environment. So we've spoken about booklet 16. Use of social media is expanding rapidly as individuals and organizations are embracing what is called user-generated content through social networks, through internet forums and personal blogs. We know that more than 90% of us use some form of social media for our personal activities. Only 65% of these sites are used for professional reasons. So we don't optimize what we do on a professional basis. And I don't think we fully always internalize the complexity of the social media environment around us and how deeply integrated it is into our daily world. There are some hidden dangers of social media. A significant amount of accounts that are created are spam accounts, and they created in order to try and find information. There's a lot of identity theft that happens. There is a lot of burglary that happens on where criminals are using social networking sites to target and burglarize houses. Now, what does that mean for us? If you keep your records on your mobile device, or you have access to emails that relate to patients on your mobile device, or you have a laptop that has your login to your electronic medical records, and that laptop gets stolen, that means that your patient's information is held on your device, is now circulated to one or many more people, and you're now technically in violation of those patients' privacy rights. And so you need to be very careful that the information that you store digitally is stored in a safe manner, either on the web using two-factor authentication, or is encrypted in a manner that third parties can't access that, even if there's a result of you losing your technology. So let's just talk very briefly about the social consultation and what a social consultation looks like. These examples have come through, and these are examples that have happened to me recently. I get a plain film X-ray that clearly has been taken through the windscreen of a car. What you can see is consolidation in the lung is a tree that sits at the back of that. And the patient says to me, what do I think? Do they, the patient, need care? And what should they, the patient, do? Now, in this case, the issue was the patient had fallen on their shoulder, and they were concerned that they had a fracture of their clavicle. Now, you look at that image there, and one might look at that image and say, well, actually, that's fairly severe. But that was a grade 1 subluxation of the acromioclavicular joint. And because of the angle of the radiograph, and because of the mechanism that it was taken, that alone wasn't enough for me to be able to give an opinion. When somebody sends a photograph like the one that you see on the right-hand side, and they say, I've sprained my ankle, what do you think? Do I need to get care? What should I do? The challenge with that is the minute they share that with you and you read it, you are now entered into a therapeutic relationship with that patient. There's a degree of obligation that you've assumed because of the fact that you've received that information, and you now have an obligation to provide not only advice, but if and when appropriate, intervention and treatment. So when patients do this with me, I say, I cannot give you an opinion based on WhatsApp, and I cannot give you an opinion based on what I'm seeing here. What do I think? I think you need to go to the emergency room, or I think you need to make a formal consultation with me and come into the practice. If they can't come into the practice, then I say to them, I need to do a formal telehealth consultation with you so that we can go through this. I can understand your mechanism of injury. I can understand the infective process if there was one. I can understand your signs and symptoms, and then we can jointly make decisions. So you need to be conscious that if a patient is contacting you, and I've had people tell me that they get contacted on LinkedIn, they get contacted on WhatsApp, they get contacted on SMS. You need to have a checklist and a formal response to limit the kind of exposure that you might have, because you might give an opinion, and off your opinion, the outcome might be adverse. You might not have fully considered everything, the patient might not have told you everything, but the patient acted on your advice. And based on your advice, their outcome is poor. We then go back to that test of what would the reasonable person do. We would fail that reasonable person test because we didn't apply due diligence, and that would result in the consequences that are undesirable. So let's just change gears very briefly. This was the American Medical Association review on digital health that was published in February this year. They did a study in 2016 on clinicians using digital tools. They repeated that study in 2019 and released those studies. What they did find is that there is an increase in the use of remote monitoring for improved care. People are using applications and devices, especially for chronic diseases, for daily measurement of vital signs, and they're sharing that information between themselves as the patient with the clinician being you. Often being able to do this remotely, removing both the patient volume risks in the practice and the commuting issues. What's most attractive about this is it's found to increase patient safety. Because the patients are monitoring themselves and sharing that information with you, it increases patient adherence, it improves your real-time diagnostic ability and your work efficiency. The reports were that it improves doctor-patient relationships, and it allows you as the clinician to provide care with the patient remotely. What you need there is an electronic health record and electronic medical record to integrate this with. Patients and practitioners have found this to be as good as traditional care. So there are trends, and these trends include this kind of technology sharing, which then makes this very key in terms of social media, because the mechanism that they share this with you on would be a social media platform. So as we wrap up the component on social media, there are 6 ways for you to stay safe in terms of your social media. The first is your accounts that have patient records in them or patient information in them should be secured with strong passwords. You should check your privacy settings on a regular basis to make sure that what you're viewing and what other people may or may not be able to view as a first and third party are important. You need to be mindful of what you share. You need to make sure that all your accounts that have patient information in have, where possible, 2-factor authentication, not only putting in a password, but also having a one-time password. You also need to be mindful when you browse that the cookies and the links and the apps that you do may lead somebody to be able to phish and steal your login credentials, and be very careful, especially in our current environment, not to accept connections or friend requests from people that you don't know. So a little bit of self-reflection, and this is now more in terms of yourself. And we're not talking now about medical misadventure and clinical negligence. We're also not talking about social media here. But what we are talking about is that there is a significant amount of healthcare providers who, whether they were directly or ancillary involved, in a incident, those persons report significantly higher levels of anxiety and secondary traumatic stress. They also report depression and they report burnout. So experiencing an event, especially one that's associated with high levels of anxiety and depression when co-workers are involved, is key. And there was a presentation that we did where we worked with a individual who spent 2 weeks in court on a frivolous claim where the patient claimed for what wasn't a genuine harm, and the patient was found to actually be in dereliction, and they were found to be wrong, and the practitioner was vindicated. But when speaking to that practitioner after the fact, we said, well, how did you feel? And their comment was, I felt profoundly alone. After the judgment was passed and I was found to be not guilty, then I had lots of friends, and my co-workers and my colleagues were saying, oh, we always supported you. But during the time that they went through this, which was several months, they felt profoundly isolated, and that the support around them was very low. So because we wake up in the morning wishing to do good, wishing to improve people's lives, when we have an adverse outcome, we feel very strong guilt, very strong shame, anxiety, fear, and depression. Because we work and live in a pervasive culture of perfectionism, we tend to internalize that. And the individual blame that we hold plays a significant role in our feeling guilt and shame. Because we don't always give ourselves permission for that, that tends to result in a significant amount of burnout, a significant amount of post-traumatic stress. That often leads to depression, and the medical profession has one of the highest levels of PTSD, depression, and suicide ideation. So medical errors contribute to mental and emotional effects. And if you've been involved in this, or if you are worried that you're involved in this, it is a very important part of your own mental health and hygiene to be able to recognize that you may be suffering burnout, that you may be suffering post-traumatic stress, and that you may need some external support. Now, in the beginning of this, we spoke about the case from Van Wyk and Lewis in 1924. I mentioned to you then that the test of reasonableness was one of two tests that was raised in 1924. The second part was that the recording of what happens is as important as the actions and outcomes themselves. So the records that you keep are fundamental in you being able to manage a dispute where there is a claim of medical negligence or a claim of misadventure. So your medical error or your perceived medical error that the patient complains about and how you acted in terms of reasonableness is equally important to how you recorded what you and your patient discussed, what your diagnostic opinion was, and how that's recorded in your notes, which you will note in terms of the ethical guidelines booklets. You need to refer to that booklet in terms of record keeping, which is booklet 9. So as we close here, courts recognize that we are human beings and not machines, and that to err is human. I mentioned to you earlier that there is a book on medical errors called To Err is Human. Let's also recognize that some mistakes lie beyond the boundaries of the standard that is expected of the reasonable practitioner. So as long as you are doing what would reasonably be expected of you, you would be regarded as having executed your professional duty. And so on that note, I'm referring you back to Michael Demand.
Brad, thanks very much for that. The last 1 minute of your talk was we lost it. So would you be able to redo just the last slide, basically?
Yeah, absolutely. The last slide. So the slide, medical errors contribute to adverse mental and emotional effect. You got that one?
Got that?
Yeah.
Next one.
Okay, so the next slide, which is then the slide on self-reflection.
Yes. So if you could perhaps just talk to that one, and then the guys will just cut it, and have you included there. It's just your internet connection went quite wonky as you did that last minute.
Okay, well, let's go back to the last minute. Was the rest of it okay?
Everything else was perfect.
Okay, so let's just go back. As we wrap up today's conversation around medical errors, and we look at medical errors in terms of both the medical misadventure and the clinical negligence component, and then we look at the nature of how a medical error can occur, both in terms of the top 10 medical errors that we spoke about, or the inadvertent errors that are created by the sharing of information through social media. I want to take you back to the first conversation in the early part of this discussion, where I referenced Van Wyk versus Lewis, the judgment of 1924, where I suggested to you that one of the outcomes was that you had to pass the reasonable person's test, in this case, the reasonable practitioner's test. And in that, make sure that you are meeting or exceeding the standards of what a clinician in your experience with your field of expertise would do. The second part of that is that the recording of what happens, in other words, your clinical records and the documentation of what happens, is as important as the actions and outcomes themselves. So here I would suggest that in terms of the ethical guideline booklets from the Health Professions Council, you also review the booklet that relates to record keeping, which is booklet 9. I also want to end up by saying, let's understand that the courts recognize that we as doctors are human beings, we're not machines, and that we do make mistakes. There is a very good book called To Err is Human, and it shares a lot of these insights that we've been talking about today. Equally, the courts do say that some mistakes lie beyond the bounds of the standard that is expected of the reasonable practitioner. So we then move, and we close this discussion by saying, if the mistake lies within the bounds of the standard that is expected of the reasonable practitioner, that may be regarded as a medical error, that's a medical misadventure, that's excusable or understandable. Those mistakes that lie beyond the standard that's expected of the reasonable practitioner would be regarded as negligence. So I want to thank you very much for your time today. Michael Demant, I'm handing the conversation back to you.
Brad, thank you so much for a very informative talk and for highlighting the pitfalls that can exist in particularly the social media space, and when the various tools that the practitioners have available to them are not used correctly. For those of you listening in, and for whoever may be interested in finding out about our further talks and presentations, please will you have a look at the social media links that should be appearing on your screen at this point. And please do follow us on LinkedIn, as well as Brad, is that thing up, that slide? I don't know.
No, it's not.
Okay. Have we got it there by any chance?
I can get it. Just give me 1 minute and I'll put it up, all right?
All right, perfect.
Then I'll go full screen to it, and then you can talk.
Okay, 100%. And then I'm just going to start from the beginning, yeah? When Brad's got it.
It's up.
Okay, stand by. There we go.
Brad, thank you very much for a most informative talk and for highlighting the potential pitfalls that exist in the social media space. For those doctors who've been listening in and who would like to hear more and find out additional information on the CPD series that Genoa is doing, please will you address the social media links that are now appearing on your screen. Either follow us on LinkedIn at Genoa-underwriting-managers-South Africa. Alternatively, follow us on our YouTube channel, Genoa Underwriting Managers. Thank you, and we hope you enjoyed this CPD presentation.
Done.
Cool.
Cool, fantastic.
Brad, thank you very much. Nailed it.
Pleasure. Yeah, that one felt harder than usual, but thank you.
Why?
I don't know. Some days they're easier, some days they're harder. I think where it comes from is I often enjoy having the questions come through to get a sense of orientation. Yeah.
Or from the practitioner.
Also, there was one or two typo things in this presentation. We're getting them more right, but interestingly, we're now going to do the social media presentation, which is purely social media. So it's actually quite nice to do them side by side.
Perfect. Is Nicola happy? Nicola, are you happy with the redo that I did? Huh? I saw your message to Dean.
Yeah. So just before you started losing it completely, I was like, no, please just ask MJ to do it, but you then redid it. So all was really good on my side. Brad, I think you came across very well today, so all good.
Thanks. One slide that we just have to be aware of. On slide 16.
Yeah.
Tim Noakes doesn't have an A. So if we can, if it's possible for us to insert the correct slide when you prepare it.
Yeah.
Dean says that is possible.
Okay.
Okay. Dean, can Dean do it on his side, or does he need me to send it to him?
If you just send me an email reminder with it, just so that I know which slide and all that kind of stuff.
Okay. So Brad, slide 16.
Yeah, slide 16. I've updated it on my side.
Okay.
And so what we're going to do now, Emdo, just to talk you through this,